Good evening, seniors and respected colleagues. In fact, I have been asked to speak on post-PCI, ultra-low LDL reduction, hydrostatins, PCSK9 inhibitors, and inclisiran therapy. I'm from Apollo Bhubaneswar. Now, 2 points to ponder. What do we mean by ultra-low LDL, and why is it so important in post-PCI cases? If we take up the first point, that what we mean by ultra-low LDL, we have to know how low we should go while treating all these patients. Whenever we thought of ultra-low LDL, we always used to think that is it safe, because we had new onset diabetes, emerging strokes, and cataracts, although we had coronary regression and reduction in the cardiovascular death and myocardial infarctions. Now, ultra-low LDL is somewhat defined as anything less than 40, and even less than 10 has been shown to be safe. This is a review that have appeared in 2021 in European Heart Journal, and they have said that the frontier for very low LDL is less than 30. Now, it has been shown that the safety is very much there. Even if you go to less than 20, the hemorrhagic strokes are minimal, and other values, other complications are quite less. Now, 2019 ESC defined that when the patient is in very high risk, one should go to 55 millimeter per deciliter, and this was again as per the Lipid Association guidelines, that if in the extreme group one could go up to even less than 30 milligram per deciliter, but it was optional, but was indispensable to go less than 50. And these were the associated factors that considered what we call as a major risk factor. And if it was category B, then it should be less than 30. Now, if you see the 2021 guidelines of the National Lipid Association, then you'll see that they also have recommended that the extremely high risk group should have LDL less than 30, and the very high risk group should have less than 50. Now, the next point is, why is it important to consider in post-PCI cases? Because we know that less than 30% of the post-ACS patients achieve the LDL less than 70, and it is very difficult to bring them to that level. And moreover, it is at the end of 1 month that maximum ischemic risk takes place. So you have to be very careful in this patient. This is as per the Horizons AMI trial. And moreover, it has been seen in the Sweethearts registry that re-MI was usually from a previously untreated lesion, which had twice higher than the risk of lesions originating from a previously stented lesion. Secondly, the prospect registry also said that the non-culprit lesions were mainly the culprit, and the prospective study also stated that one should be careful about the non-culprit lesions, which can cause more trouble in the future. Now, when we think of a plaque stabilization, we're worried about this thin fibrous plaque, and we know that statins, PCSK9 inhibitor, and inclisiran all work on this to somehow decrease the plaque burden and also the TCF, a thin fibrous cap, as early as possible. Now, I have three agents to use: hydrostatins, PCSK9 inhibitors, and inclisiran. Coming to hydrostatins, we know that when you use hydrostatins, that is a mortality benefit, as you see in the blue line, has got the least this thing that is mortality if it is in the highest intensity. When atorvastatin and rosuvastatin was compared, it was shown that rosuvastatin was definitely more effective than atorvastatin in reducing the microinflammation of the ACS patients especially. The Stellar study also stated that the greatest reduction did occur when rosuvastatin was used, as well as high-dose rosuvastatin up to 40 milligram. Now, the Asteroid study clearly stated there is significant regression of atherosclerosis if you use high-dose statins to the tune of 40 milligram of rosuvastatin, and the LDL could be reduced by 53.2%, and also we can 75% of the patients achieved LDL less than 70. The Saturn trial was also something which also proved, which was by Nichols and Valentine, which stated that regression of atherosclerosis was observed in approximately 2/3 of the study patient during the 104 weeks of statin therapy. So high-dose statins do work, and that is the reason why we do preload the patients who are undergoing PCI, and meta-analysis has shown that it significantly improves the myocardial perfusion, significantly improves the TME flow, reduces the major adverse cardiac events, reduces the perimyocardial injury, and of course reduces the spontaneous myocardial infarction, target vascular revascularization, especially for ACS and statin patients. Then can be recommendation, a 1B recommendation to add HTMB, and we know that if to add HTMB, it becomes directly a one-step co-administration instead of going on increasing the statins to a 3-step titration. Now, we have seen that adding HTMB has got a much better role if compared to a statin alone, and you can see the LDL reduction is much higher. These drugs do not work in much cohesion, and especially statins do have anti-inflammatory and anti-thrombotic effects. And this drug HTMB, in addition to all this, has got steroid reduction, vasomotor cell proliferation inhibition, and also the cholesterol crystal reduction. Then coming to the PCSK9, we have seen the 2018 guidelines stating that the PCSK9 inhibitor has to be used when you have used statin and HTMB and the patient is not under control. You should go for a PCSK9 inhibition so as to bring the LDL less than 70. So the 2018 guidelines. Now, studies came up that during ACS, the PCSK9 levels are high. So that is the reason why in ACS situations, you have to give PCSK9 inhibitors. And it was seen that PCSK9 levels were related to the mRNA levels after MI, and it was seen the maximum level were at 48 hours. So the earlier you gave, the levels of mRNA decrease, and PCSK levels also, PCSK9 levels do decrease. Now, why are this PCSK9 levels important? Because in ACS, the PCSK9 levels increase, and this lipid core becomes unstable, and as a result, there is an independent predictor of coronary artery disease. Now, there is a recent study which is about to be published. It shows that increased PCSK9 levels are also associated with higher platelet reactivity and are a possible predictor of ischemic events in ACS undergoing PCI. So that is the reason why PCSK9 inhibitors have to be used earlier. The Fourier study, not done in acute situations, have definitely shown that we had a significant decrease of LDL by 59%. Higher was the risk, for example, if they had high risk of 2 prior MIs, multivessel disease, diabetics. This drug was well tolerated and it was safe, and that is what we learned from Fourier. Further evidence came from the EVOPAX published in November 2019, the OCT trial in March 2020, the EVAX in July 2020, the IVAS virtual histology in 2020 November, and the latest NMR study. Now, the EVOPAX study clearly showed a 77.1% compared to this thing, the patient, those who are on placebo with statins. And it, of course, majority of the patients, 95% of the patients achieved the ACC-HA goal, and 90% of patients achieved the EAC goals. Now, the EVAC study also showed that within 30 days, there was almost a 62% reduction in the LDL compared to a placebo only. Now, the proportion of patients who reached their targets were all to the tune of 80%, and the guideline recommended LDL targets could be achieved in ACS patients almost within 30 days. A more important thing was the small dense LDLs were remarkably reduced, and the LPA, which was increased when statins were used, had a reduction when you started putting these patients on PCSK9. There were some learnings from imaging studies. The Athroma IVA study showed that the PCSK9 levels were independent of the serum LDL. There was no correlation, and the level of statin use. And the PCSK9 levels are also directly related to the lipid core burden. So that is why there's every reason to use the PCSK9 inhibitor post-intervention. The OCT trial tried to show that the length of the coronary lesion and the fibrous cap, you see this is a pre-PCSK9 use, where the fibrous cap is quite thin, and you see the thickening of the cap and the arc decreasing. This was studied, this was the OCT studies which are from Japan. Then this also showed that the lipid arc decreases, the lipid length decreases, the macrophage grade decreases. The NIRS IVA study showed that definitely there was, the study suggested clearly that the plaque morphology can be altered by the aggressive lipid lowering therapy by using a PCSK9 inhibitor. So the most important thing, higher was the risk, higher was the chances of the benefit that the patient would get. Next, the LDL cholesterol was achieved to less than 30 to 50 in most of these patients, and this prevented recurrent cardiovascular events. This is from the trial study which was published in 2019. Now, starting about comparing about revascularization, whether it's a complex revascularization, a CAPG, a complex PCI, all you see start having divergence almost after 12 months. And they also, the forest graphs almost show the benefit whether on multiple stents used, bifurcation, a complex angioplasty, or the stent length is very high. Now, so why start PCSK9 early post-intervention? Because definitely the stabilization of the plaque, there's a decrease in the inflammatory monocyte recruitment, which is a known cellular plaque component that triggers the destabilization. and both the culprit and the non-culprit plaques are stabilized, and it is whether you give early or immediate administration of the antibodies in ACS before the coronary intervention is advisable to reduce ischemia and stabilize the plaque. So now it is like giving aspirin, ticagrelor, and atorvastatin. You should give an injection of PCSK9 before you take up the patient for a PCI. Lastly, coming to inclisiran, we know that this besides statin and PCSK9, inclisiran is the next, which works through the mRNA and somehow decreases the PCSK9 levels production in the long run. Now, there have been two studies, the Orient 10 and the Orient 11, which has shown that with inclisiran, there is almost a 53% reduction, and Orient 2, which was done in Europe and South Africa, showed a 45.8% reduction. And this is what happened at the end of 3 months when inclisiran was used, and it was maintained almost up to 18 months when the study was stopped. And the favorable product result was that there was almost a 55% reduction at almost 510 days. So if you try to compare all the strategies, you'll see that if you use only a moderate incidence statin, 30%, high incidence statin reductions 50, with ST5 65, PCSK9 was 60, PCSK9 with high incidence statin 75, and PCSK9 inhibitor with intensity high incidence statin with ST 85%. So this is what we expect if we use all these three drugs together. So the treating LDL this last quarter has been that we all started with the triple 4A study, then gradually the other statin studies came, then came with HTMB, then came the 4A study, and gradually realized that lowest is the best. And so to make a long story short, number one, try to achieve the ultra low LDL, which is safe to prevent further events. High intensity statins therapy has to be loaded in PCI and ACS. If already on statin and STB not reached the target, start a PCSK9 inhibitor. And PCSK9 inhibitor given early in ACS and in PTCA patients is definitely beneficial. That is emerging role of pre-PCI PCSK9 inhibitor which has to be used, and possibly the next drug which is emerged to be inclisiran, which is not available in our country but is available in UK. So as it is said, that do not wait to strike till the iron is hot, but make it hot by striking hard. Thank you very much for the patient hearing.